My name is Anna Andreou, and in this video, as part of the Trigeminal Neuralgia Awareness Campaign, we will discuss with Professor Joanna the treatment of trigeminal neuralgia. Professor, thank you for being with us today. Can I first ask you, what will be your first approach when you're treating a trigeminal neuralgia patient?
So there's no doubt at all that the first treatment of choice are the anticonvulsants. And first line are carbamazepine or oxcarbazepine. And if those prove to be less effective or there are tolerability issues, drug interactions or sensitivity to the drug, then we change into the second-line drugs, which include lamotrigine, gabapentin, baclofen, pregabalin, phenytoin. So we have a range of drugs, but all in really the anticonvulsant group. Analgesics do not work in this condition.
So with the patients, you will initiate a prophylactic, a preventive treatment. And when you consider changing the treatment from one anticonvulsant to another, for how long do you wait?
So very much depends on the patient diary. I encourage my patients to keep a diary where they note down the effectiveness and tolerability and effect on quality of life. Because the other problem is that trigeminal neuralgia has its own natural remission period. So the diary gives us a better indication of where the patient is heading. So it's starting low and slow with any of those drugs. But once we reach maximum doses and there's no effect or the tolerability is poor, that's when we switch to second-line drugs.
And when these treatments are effective, how effective can they be? What should the patient expect from these treatments?
Well, surprisingly, even 100% pain relief, much higher than in other neuropathic conditions. And it is very important that patients realize that it won't get rid of all of the pain attacks, but that their intensity will diminish as well as their frequency.
Is there a percentage you will consider a success in your clinic?
50% reduction is certainly something we aim for.
That's perfect. And when will you consider a surgical approach, a more invasive approach?
Well, it's very important that patients have an awareness that there are secondary approaches, that is neurosurgical. So I think it's very important that while the patient's in a good state, that is not totally dosed up by the drugs, that they have a discussion with the neurosurgeon together with a physician to decide on what treatment options may be used in the future. So when they have an acute attack, that is an option that they can go for. But we have no prescribed way of saying, this is the moment to have your surgery. It's not if you have tried so many drugs that you have surgery. It's very much up to patient decision-making.
And what type of surgeries are available for these patients?
In patients who have a neurovascular compression, then microvascular decompression is the option. There's no doubt the success rate in the good hands of a neurosurgeon that does many of these procedures is excellent. We're looking at 70 to 80% of patients being still pain-free 10 years on, and we can't achieve that with drugs in any way at all.
And what about other surgical approaches like ablation?
Ablative procedures are very effective, particularly in elderly patients who cannot undergo surgery. And these range from any three Caesarean ganglion ones, radiofrequency thermocoagulation, balloon compression, or glycerol. And the fourth one is stereotactic radiosurgery, which is aimed at the posterior fossa. Now, the problem with all of these procedures is they are destructive. That is, they lead to sensory change, unpredictable how extensive it's going to be, and carry the risk of anesthesia dolorosa. With stereotactic radiosurgery, one has to be careful that there are delayed responses. So it can be up to 6 months before patients have a response to treatment. So not a treatment for an acute exacerbation of trigeminal neuralgia.
And it sounds like we do need to have a multidisciplinary approach for these patients, right? I mean, we need the neurosurgeon, the consultant that will make the diagnosis to begin with.
I think this is crucial because one of the things we have found that fear drives a lot more pain, loneliness because they don't meet other patients, and ways of coping with flare-ups. So I make sure that my patients have what we call a flare-up plan. And psychologists, physiotherapists are important, as you don't bite on one side, you avoid using one side, so you're more liable to get temporomandibular disorders. We have nurses who help with medication and advise patients about medications. And also, very importantly, is a patient support group, so that patients can talk to other buddies, as they call them, other patients who are going through the same problems as they are. And that's an integral part of the management.
So for the management, so far we covered more about the preventive side. Is there an acute treatment you will consider for the patients? And for which patients will you consider acute treatment?
Patients will get flare-ups, and these are very severe. The attacks are so frequent that they feel as if the pain is continuous. They often will go to the emergency room. They become dehydrated because they cannot take in any food or even fluids. And those patients will often need an admission to hospital for rehydration. We can then use phenytoin or fosphenytoin as IV. We've also found, being from the dental world, that giving dental injections into the trigger points can help stabilize as you increase the dose or change the oral medications. So you can give frequent dental injections until you get to the best drug treatment. And then if those don't succeed, then probably an ablative procedure is the next phase, because that can be done at very short notice. It doesn't require much time in the operating theatre, whereas a microvascular decompression is several-hour procedure.
Of course. And what other treatments are there? I mean, what should the future bring?
Well, surprisingly, for so many years, we've done with the old anticonvulsants. But we now have 2 drugs that are undergoing phase 2 trials. Zakrzewska, which is a sodium channel blocker, which has shown to be very effective and surprisingly very few side effects, which means tolerability is increased. And we're currently running another international trial on basmiglucerant, again, another treatment choice. There are also, I know, another 2 drugs being considered, one of which is a repurposed drug. So there is light at the end of the tunnel.
Well, it's a good message for the patients that there will be new treatments coming up hopefully soon. What will be your message to the clinicians?
I think getting the diagnosis correct and having a definite plan, plan A, plan B, so patients know what the whole process can be, and to have psychosocial support throughout the disease process.
That's perfect. Professor, thank you for being with us today.
Thank you.